So if something doesn't jive, it's because we probably just made them up. But that way we can record them. If you guys needed to go back and look at what, for some reason, wanted to see how we work through the website, you'll be able to do that. Since these are going to be just made up things, and we can do that. So
all right.
Jill's probably almost on, I would think.
Probably. You can go ahead and get going now. I've got
Okay.
my screen share up for now.
All right. So what we're going to do is I'm going to start with a case that's basically completely made up, and we'll just work through it. So these are sort of pulled together from people that both Jen and I have seen, but it's no particular person. So I made up a case of a 66-year-old guy who's presenting for treatment for hepatitis C. And as far as risk factors went, his first IV drug use was around age 19. His last IV drug use was around age 35. He never had sex with other men. He never had any blood transfusions. He had one unlicensed tattoo at age 19. I made up he was first tested in 2012, and he's never been treated. He has a history of former heavy alcohol use, but he's not drinking anymore. As far as his other medical problems, he's got a history of coronary disease. He's had an MI before. He's 66 years old. He's got hypertension, dyslipidemia, AFib, diabetes, history of VTAC, has an ICD-10, kind of like a lot of people you guys see. So as far as his lab workup went, I'm trying to use the sheet that we asked you guys to use, and I will tell you that. He has genotype 1A. His viral load was 2,400,000. He's got his hepatitis B surface antibody is positive. His surface antigen is negative. His total core antibody for hepatitis B is negative, and his hepatitis A antibody is negative. So with that background, why don't we try to start working through our sheet here a bit. Oh, and his medicines, he's on metoprolol, aspirin, Eliquis, amiodarone, atorvastatin, lisinopril, and he uses Lantus insulin. Now, we're just going to go through our treatment worksheet here. All right, there we go. So question one, we know he wasn't infected in the last 6 months just based on our history.
Can everybody see the treatment assessment?
No.
Go ahead.
Okay.
Well, you guys
No, there's a block. There's something blocking the front.
Okay.
Different browser.
Jill, I'm going to hand it over to you, okay?
Finally got here. Sorry.
All right, you're already set as a co-host, so if you can get the site up for us.
Well, I'm having major technical issues today.
Oh, good. That's seems to make two of us.
I've been trying to connect for the past 10 minutes.
Okay.
Okay.
So let's just.
Can you pull up Firefox?
Perhaps.
I can't do it from here. I can't even get there. I'm sorry.
That's okay.
Can I do it on this one?
Drag a little bit. So let's get rid of that guy.
Is that full? Where's Jill?
Let's just go. Firefox doesn't want to work for us. Jill, are you using Firefox at the library? I'm just wondering if maybe we've got some network issues.
I usually do use Firefox here, yes. And
Yeah,
it's
it's down for us.
There we go. Now I'm up. Can you share screens with me?
You can share.
I
Your
can
set.
share.
So if you just hit your little share button,
Uh-huh.
let me get rid of this.
You just minimize it? Okay.
All right.
I don't know why this isn't coming up at all. This is slightly embarrassing.
Do you want me to share screen because I have it up?
Whatever works. It's loading, but the network here for some reason is really dragging.
All right, Raju, you're set. If I made you a co-host, if you want to share the screen and you want to take a stab at clicking through like you're treating the patient on your own, let's
That'd be
do
great.
it.
That would be great if you could do that.
Thank you.
Can you guys see my screen?
Yeah,
Sure
Yeah.
can.
Okay.
great.
There.
Perfect.
Real life experience.
Thank
Okay.
you.
There you go.
So the first question we know, like I said, he's been infected for a long time. We even know that by the history. Remember, his IV drug use and his tattooing was in his early years, so we know he's not been set the last 6 months. His viral load we knew was 2,400,000. His genotype is genotype 1A. I don't know if I mentioned that. And he's never been treated before. So what the first thing we want to do is get his liver disease stage. So why don't we click the staging algorithm as our next step? Great. And so what we'll do is we'll calculate his FIB4. And I'll give you the numbers there if you want to hit the click here to calculate FIB4.
Top left.
And that's on the top left.
The other one on the other side. There you go.
There it is,
Click
yeah.
here to calculate FIB4. Okay, so his age is 66. And his AST, let's see what I gave, 45. ALT of 86. And platelet count of 141. And that gives you a 2.27 FIB4. So now we have our FIB4 score, and we can now close that window and go back to our algorithm, if we can. Everybody with us so far? And now, can we make that any bigger or no? That's good. So if you see there, we're on the 2.24 FIB4 is in the middle ground, that yellow part. So we need to do another test. And I arbitrarily made up a point where he can't get he's too far away to get a liver elastography. So we're just going to use, like the algorithm says, we're going to do a fiber test. And again, I'm making up the number, but his fiber test I'm giving you is going to be A3F4. So he's got cirrhosis. And let's go through the algorithm just so we can see how that would work. So he's at his FIB4 was what, 2 point something.
Yeah.
Okay, so we go to both fiber test and liver elastography less than equal to F2. That's not true. Let's see, both, or where is it? Or I'm just trying to find it.
Here.
Okay, we're in the middle here. Either fiber test or liver elastography F3 or elastography not available. And he's going to decline a liver biopsy for us. So we're going to assume he's F4. Does that make sense to people? How we got there? Okay, good. So if we're assuming he's an F4, I'm assuming he's cirrhosis, the next thing we need to do is calculate the Child-Pugh. And if you go back up on that algorithm, you'll see that now. Perfect. Okay, so we'll plug some numbers in there. Let's see what it's asking for. His bilirubin, let's see what I gave his bilirubin to be. 1.1, so we're good there.
Albumin.
And the albumin was 3.5, so in the middle there. And his INR was, what did I say it was? His INR was 1.3, so we're good there. He has no ascites, and he has no encephalopathy. So our Child-Pugh class is 6, and so that's Child-Pugh class A. So now we know that he has cirrhosis, and we know his Child-Pugh score. He's got compensated cirrhosis. So let's go back to our treatment worksheet now. We can, if you can go back one screen. Yeah, there you go. And now, okay, so we now know that he's Child-Pugh class A. And now we can go to the guidelines and see what treatments would be recommended for 1A with compensated cirrhosis. And what you do is you hover over there where it says treatment naive. See that at the very that top bar there? Oh, no, you can go back again to the, yeah, just hit it again. If you look where there's that dark black section in the middle there, that band, it says treatment naive. There you go. And you want to hover over genotype 1. And you've got compensated cirrhosis genotype 1A. We're going to call him 1A. There you go. Now just click that. And there's going to be our choices. Can you scroll down? Just there you go. So our choices are, let's see, that one is, the first one is Zephyr for 12 weeks, assuming that he doesn't have an S5A resistance. The second one there is Mavuret, or Gocapivir for Bemtasivir. The third one is Harvoni, and the fourth one is Epclusa. So there's basically our 4 options. So now if we leave this screen just for a minute, and we'll go back to our pre-treatment worksheet. So we now know what the guidelines say we could use. Let's just make sure we did all of these things there. And we're going to assume that since he was hepatitis B negative, you're going to vaccinate him. You're going to vaccinate him for A and B. You're going to test him for HIV and make sure he's HIV negative. And you're going to do what that last one there, that if he's F3 or F4, which he is, you're going to want to get an ultrasound, and you're going to want to get an alpha-fetoprotein level before you treat him. The reason you want to do that before you treat him is if either one of them is abnormal, you should hold off and just send him to either us or to GI, because sometimes if they have tumors, they are liver transplant candidates, and you don't want to treat them before if they need a transplant, because that can lower their transplant pool. If they need a liver, it's better to have them set beforehand, because they can get a liver from someone with Hep C. If you treat them ahead of time, then they can't get a Hep C liver. I know that's hard to fathom, and it's counterintuitive, but basically the bottom line is we're going to say for this guy, his ultrasound was fine and his alpha-fetoprotein level was 2.5, which is fine. So all you really want on the ultrasound is, does it look like he has a liver tumor or not? If there's anything that suggests he's got a liver tumor by the radiologist, you send him to GI or ID, and then we'll take care of it. But let's say for this case, he's fine. So let's go to our next thing, which is, are there drug interactions to consider? Let's check that. And we're purposely going slow here, but you can do this a lot faster when you really do it yourself. I just want to make
I'm going slow.
No, take your time. You're
That's
doing
good.
great.
You're doing fine. I just want you guys to see the steps and that it makes sense to do it this way. But when you're doing it on your own, you can zip through the stuff.
It's taking a long time to load.
There we
Oh,
go.
no.
Might want to try reloading it.
All right.
Everybody's network is going down. It's the internet apocalypse.
Yeah. Really. And I have a tax appointment today, so this will be really good.
So why don't we try this? Why don't we get all the way out to the main home page if we can? And if I have to, I'll tell you what the drug interactions are, but I wanted you to be able to see it, but so be it.
Let's see if it's,
I don't know why that's not loading.
Liverpool.
Just put in Liverpool Hep C right there and see if you can get it to come up, even though if it's not coming up on our site. If you just type in Liverpool Hep C in Google, you should get it.
It's coming up on regular computer, so I wonder if it's that link. That shouldn't.
There we go.
So it normally will work from our
Yes.
link there. I don't know what happened.
Maybe I should stop sharing. Do you guys have it up now? Because it doesn't seem to be working on my end.
Honest-
Let's try that.
Honestly, I stopped trying. You were doing such a great job.
Yeah, you did great. We'll try it again. We'll try it on our side.
Yeah, we're gonna
Let's
take
see
over.
here.
So let's go back to our site and see if you can get it to work from our side.
Absolutely.
All right, we want to go to can you make that page big?
I'm just going to grab this.
All right. Good. Now, let's see if it'll work for us.
Fingers crossed, everyone.
Yeah, there we go.
Yay.
Can we make that complete the big screen? Make it all the way, maximize it, in other words, is what I'm trying to say. Or maybe it is maximized.
It is.
It is
Maximize.
maximized.
Okay. So hit, the first thing you want to do is hit, I can drive this part.
Go ahead. You
All right.
knock yourself
That way you
out.
can,
That's
don't have
perfect.
to.
Don't
All right,
just
so you-
type
I
it.
don't
what
have
you
to
wanna do
spell
is-
things.
Interaction checker. We're going to put in, now remember, those were the drugs. You don't even have to know for the, this is one thing I'll tell you about this site. You can put in the brand names in the Hep C drugs, but you got to use the generic names for the other drugs. If you want to enter, thanks.
Sure.
Okay, so what we're going to do is we're going to put in Epclusa. And you can check that one. And then we're going to put in another one. We're going to put in Harvoni, just like it said we could use. Remember, this is genotype 1A. All right, good. And then we're going to put in Zepatier. Good. And we're going to put in Maburet. Those are our 4 choices that it gave us. And so we'll put those in. And now we're going to cross-reference every choice against the potential drugs he's on. And we're going to say he's on metoprolol. And good. We're going to say he's on aspirin.
Aceta.
No, aspirin.
I tried
ASA,
ASA.
salicylic acid. Don't worry about it. We know it. Aspirin doesn't interact. Take my word for it.
Aspirin's fine.
Okay, we're going to tell you aspirin's okay. Rivaroxaban. There we go. Good. Amiodarone. All right, atorvastatin. Good. And lisinopril. And we're going to leave Lantus out. It doesn't interact. Everybody knows that. Okay. Okay, now we're going to scroll down to at the bottom of that screen where it says PDF. And we're going to download the PDF. And that's going to give you a report of every single. Good. And can we
No,
maximize?
they can't see it. It's
Can we-
blocked again.
Is it blocked on you guys?
It's IE.
What does that mean?
Don't know why. Go ahead and do resume share right here and see if it comes up.
Well, we can look at the side here.
Can they see that?
So can you see where I'm pointing? Where it says do not co-administer? So
Yeah.
you can download the PDF or you can look at the side here. So you can,
Yeah, we can scroll down and show them that.
so what it does is it lists out things that you should not co-administer. So here we see atorvastatin should not be co-administered with Mavuret. Amiodarone should not be co-administered with Harvoni. You shouldn't give amiodarone with Epclusa.
Yeah, there you go.
So these are things that absolutely should not be administered together. And as you scroll down, it kind of lists them like do not administer with, and then it goes to potential interactions, and then beyond the bottom is usually listed things that are okay to do together.
Right. And
So we see here that,
and you can click on each one of those if I remember right. You can click.
correct.
Let's
So
do
let's
that.
go back up to the top here
Yeah.
and look at atorvastatin and Mavuret.
It says, yeah.
And when you click on it, it tells you why in summary. Can you see that?
Can you guys see that?
Yeah, so it tells you about the potential interaction that the patient may experience.
And it also will sometimes tell you how to get around it there. So if this is, it says there co-administration of atorvastatin 10, it still increases the levels substantially of glucophagir and piperacillin. What you can do in this situation is put in an alternative. Just go back to your, let's do this. Close up a minute. So if you can't use atorvastatin, think about what you could substitute. And what I usually use myself is I put in rosuvastatin, just so you guys know. That's a one that you can usually use with if you don't use too much. And now if you, that just automatically will get added.
So
Okay.
can't give rosuvastatin though with Harvoni.
But if you go down to Maburet, you'll see.
So I'm going to scroll down here.
Yes.
So here's Mavuret
And if you click the orange one there,
and rosuvastatin.
basically what it's going to tell you down there is that the European guidelines say you can give 5 of rosuvastatin, and the American guidelines say you can give 10. But you can give rosuvastatin with Mavorec. So that's why you can get around that. And the important thing here is if you look at all the possibilities, if you do that, the main thing I wanted to show you guys is that for things like, let's go back to the drug interaction main page again.
Yeah.
The main thing I'm trying to really get at here is that even though Epclusa is probably going to be the new favorite one out there for the insurance companies, but anybody on amiodarone, you can't use either Harvoni or Epclusa. And that's really why I wanted you to see this, is that amiodarone is not something that you can usually substitute for. Think about it. Everybody knows that. They're usually on it for a big reason. And so that means that really, you might as well take those right off your list of what you can use here. So you can forget about Epclusa, you can forget about Harvoni. If they're on amiodarone, it's a done deal. So that leaves you Zepatier and it leaves you Mavorec. Zepatier, you would have to do resistance testing to find out whether you could use it, and it's got no advantages over Mavorec, and it actually costs more, so you're left with Mavorec. And so let's go scroll down to Mavorec one more time. So if you're in this orange category, all you got to do is think about, well, what can I do? I know it's got amiodarone sort of yellowed out there, but it's okay.
Right.
So what you can do here is you can substitute rosuvastatin for atorvastatin and use 5, or if you want to, use 10, and you'll be okay. And so basically from this exercise, I'd say we can use Mavorec. Is everybody with me on how we got there?
Yeah.
Okay, let's close this out a minute. Okay, let's go back to our main page.
Do we have the,
You just have this.
share?
Yep. And then grab the like button.
Let me go back maybe.
Yeah, good.
No, it's drug interactions. You want to go back to the Echo site?
I want to go back to the Echo site. It's probably underneath that little thing. You just can't get at it.
No, it's, we want to take
I
it
can
in the
get it,
site.
yeah.
Yeah, we'll pull it up. 1 second.
All right. So,
And I just wanted to add, because I recently came across this where I had a patient who was on atorvastatin, but I had the benefit of the fact that the patient is her primary care provider is in the same clinic that we're in, and I went back and looked at her cholesterol numbers, and so I felt like it was appropriate to just stop her atorvastatin for the 8 weeks that she's going to be on treatment, because her numbers looked really good.
yeah, that's a good point, because
So sometimes you don't even have to try and replace it. If it looks like that's something that they could live without for 8 weeks, then maybe that's the way to go. Then, as opposed to further confusing things by adding a different drug for 8 weeks and then going back to your old drug.
Yeah, and that's a good point. If you've got somebody that's just basically hyperlipidemia and does not have a coronary event, I think that's a reasonable strategy. This particular guy who's had an ICD and everything else, you probably do need to substitute something. So again, it's kind of a judgment thing, but let's go back to our pre-treatment worksheet one more time now and see where we are. I want to go through the entire worksheet and make sure we get to cover
what happens
everything.
if you minimize this? Just for the heck of it. Minimize, yeah. All right. Can you see the pre-treatment?
Can you see it?
No.
Yeah.
Different. Can you use screen Firefox?
No, because we couldn't even get Firefox to boot. Yeah, close that.
Okay.
And now.
Right.
Okay.
Wow.
One more time. And yeah,
You want me to share?
Yeah, if you
Can you see that?
we can do this for now. That should
All right.
work.
All right, so let's go straight. Can you guys see it?
Yeah.
It's up now?
Yep.
Great.
All right, so let's see where we are. We just did our drug interaction
So we did
thing.
drug interactions.
We did our child Pew calculator already because we did it on the staging algorithm. He's not pregnant. We're good there. And the Prep-C assessment tool, I just put this on there. But I don't actually use it. It's basically whether you think somebody was going to adhere to the drug. But you're going to get a good feel for that. If you want to use that thing, it's there. I've never actually used it, but it made my form look nice. So
I've had to use it one time at the request of an insurance company.
Right.
But that was one time in, I don't know how many patients now
Me
that
too.
I've treated
me
in the
too.
last 2+ years. So,
I've had to use it once.
right.
Okay. So I think we're done our sheet, and we've already settled on Mavorec, right? I think at this point.
Yeah.
So let's go to our treatment part.
Sorry.
All right. Sorry, I'm gonna go ahead and see if I can get 2 windows up and
You pulled up Chrome.
I
now it's
did.
hard to tell.
that's okay. I'm gonna see if I can do a screen share of my desktop instead of screen sharing the web browser.
Mhm.
And then everyone should be able to see everything and do 2 things at once. If I can get anything at all to load. Hey, Jill. How's
Hey,
your
yeah. I have everything up on my screen.
Go crazy. Go
All
ahead
right.
and share.
So we're going back to the Maverett worksheet.
Yes, please.
And just go back to the main page so you can show them how to get to it.
Where did my share go? No. I lost my share. There it is. Back to the main page. So let's go back. All right. So from the main page of the Hep C website,
So yeah, we
Maverett's
did
in the
update
second
treatment.
column.
Exactly. So there it is. Go ahead, Jill.
Maverett, I clicked there and it's already opened.
And
Here.
so, yeah, so now let's look at that just for a minute.
Hold on. Sorry.
Okay, that's all right.
There we go.
Okay, so you see those choices here, 8 weeks versus 12 weeks. Look at the eligibility for the 8 weeks. It says any genotype, which is true, but it also says no cirrhosis. So we're not going to use 8 weeks here because we've already said this guy's got cirrhosis Child-Pugh class A. And so if you look at the 12-week side in the green there, any genotype in Child-Pugh class A, and if you forgot to calculate the Child-Pugh score, you can do it from this page if you wanted to, all right? And then if you get a B or C, you just got to send them either to GI or to us, okay? But let's now say that we've got a Child-Pugh class A, which we did. He was Child-Pugh class A. This is what you're going to do. You're going to put in that viral load, which I said was 2,400,000 as your time zero. It doesn't matter if it was 6 months ago. As long as it's been within a year, you can use those values as your time zero. And you'll put in like your AST and ALT in there, what you're starting out with. And then, so if you're today, say what is today, the 7th? So you count 3 weeks from today and say, okay, what is that? The 21st or whatever it is.
Right.
28th.
So if you're 3 week, you can say, fill in that thing March 28th, you're going to draw a viral load and you're going to draw LFTs. Okay. And if your LFTs go up by 3-fold, which I've never seen, but really maybe that's been associated with, drug-induced hepatitis, that's why you draw the 3 week LFT. And the 3 week viral load is for the insurances to be happy. But just in case, because it can rarely be associated with it, you do the LFTs there. Like I said, I've never seen it. I don't know if you've ever seen it, Jen.
No.
Okay. So we're going to say for there that, our viral load should be below 1,000 at that point. I've never seen it not be if somebody's taking the pills. And the insurances are going to say, go for it. So then we're going to calculate out where our 9 week place would be. So if we started out today on March 7th, we just calculate out to 9 weeks. And we draw our LFTs. Again, this is because, notice we're not doing a viral load this time because we're not done treating yet. What we're doing here is just making sure that the drug is not harming the liver. So again, about 9 weeks out, we'll draw up more LFTs. And assuming that they're not up again, we're going to move to the next part, which is when we are done treatment. Remember, it's a 12-week treatment, so you draw basically, and remember the time zero is today. It's going to take about a week for the drug to get approved. So at 13 weeks, you should be at the end of treatment because it took about a week for the drug to get approved. Is everybody with me on that? Okay. So here, I don't know what that 13 weeks would be from today, but that's your date that you put in there. Okay, so you're talking May 9th. So, and what I always do is say, today is what, Thursday? Okay. What I just tend to do myself is I'll make it the following Monday just to make sure that they finish their drug. Because what you really want to do on this last one is to make sure that if it's a week late, who cares? But you don't want them to still be on pills. And you want them to be finished so you really do have the end of treatment response at that point. So that you're looking at a true end of treatment response. And then again, you look and at week 14, you bring them in so that this is your first, but notice this is the first time they come back to your clinic. They finish the treatment by the time you're seeing them again. There's no reason to bring somebody in. We don't do it. I don't know what other centers do. We tell these people, we trust you to take your pills. If you're having trouble, contact us. But we're not going to see you again until you're finished. There's no reason to do that. We'll look at your labs. We'll make sure everything's going okay. But why make them come back in just to say, oh, you're taking your pills? Well, great, you're taking your pills. So the next time you see them is when they're done, which will be basically 14 weeks out. And hopefully at that point, they've got an undetectable viral load. You still want to see the LFTs then, but if they were up, they're done the drug then anyway. So you don't have to worry about it's going to cause more things because it's done. And, I've never seen anybody not have an undetectable viral load at the end of treatment, ever, with these drugs. I don't know if you have, Jen. All right. So you're going to most likely go on to week 25. Again, time 0 being today, week 25, wherever that is. And that's going to be where you finally are going to find out, did the treatment work? You want to have at least 12 weeks after they finish their treatment. So what I usually do is when they come back and see me on week 14, I will figure out I'll ask them when they stopped, when they finished. And if they can't tell me, I'll just do my best to figure out, make sure that they, say, I'll pick a week where I know that they've truly finished and count 12 weeks from there. Again, you can go by the sheet if you want to, but you can also, this is for your guidelines. It doesn't have to be strict. You just really want to make sure that they've had more than 12 weeks or more after they finish treatment, at which point you want to get a viral load. And it should be no virus 12 weeks post-treatment. If there is any virus 12 weeks post-treatment, send them to us because that's a failure. I've not seen it, but in our clinic, I've seen 3 failures in 4 years. And 2 of the cases, they just didn't take the pills right. And I think 1 was a true failure. So at that point, if we can scroll away just a little further over, I want to show them something on this form that is important for them to see. Can you move the form over, Jill? Where they can see 26 weeks clearer? There we go.
No.
Can everybody see that still?
Yeah, we can see.
Okay, so it says viral load undetectable. So this is when you're seeing them back a second time. This is only the second visit you do with them. And again, you just want to go over the test with them. If their viral load is undetectable, they're done with 1 big asterisk. Remember, this is in the cirrhosis category. That's why you're on the 12 weeks. And if you look down at the bottom there, it says, under the asterisk, regardless of SVR results, all patients with cirrhosis should be referred to GI for an initial screening EGD and have lifelong serial hepatic ultrasounds and alpha protein levels every 6 months. And then you don't, if either of those become abnormal, you send them back to GI. And notice I'm not saying to send them to Jen and I because we're not GI people. So this is where you really do have to send people to GI if that happens. And you do have to send them for the initial evaluation for a screening EGD. Now, can we scroll up and so we can show the difference at the 8-week period? Because remember, the 8-week folks don't have cirrhosis. Can you move up on the form, Jill?
Yep.
So there it says viral load undetectable, done, and there is no asterisk because you really are done. You don't have to do a thing else with these people. They're finished. And you do want to remember to tell them that their hepatitis C antibody test is going to be positive forever, because we've had more than one patient referred back to us because 2 years go by and somebody tests an antibody test, it's positive, and then they get sent back for retreatment. Well, they don't have it.
Yeah.
So their antibody test will be positive the rest of their life. You're not even supposed to check a viral load again because there's no need to, unless they have otherwise unexplained LFTs that go up again, or they have ongoing risk factors to get reinfected. But if somebody's in their 68 or 69, they quit using drugs 30 years ago, that's not going to be the case. So I just wanted to point that part out. Also, you need to tell them, and we're going to put this on a post-treatment worksheet, which I still have to make, but Jill and I will work on that. You want to tell people, too, that since their antibody test is positive, even though it doesn't mean they have the virus, the Red Cross won't let them donate blood. It's just the rule. But they can still be organ donors, even with a Hep C antibody that's positive. And that's counterintuitive, too, but we always try to tell them that. And I think it's also important to tell them you're not a carrier. Some people get that confused. They think, oh, I could still even transmit it. You really do tell them it's gone. You're not a carrier. It's not like you can give it to anybody else. I've had that confusion before. Mm-hmm. And the other thing you want to tell, because I've made this mistake, and I'm going to present a case to you where I've done it, which is if they are still at risk to get Hep C, you have to tell them that they can get it again. Because some people are under the false impression if they got cured from it, they're never going to be able to get again. That's not true.
And I would argue, and that's part of the conversation that I have with anybody that I treat, is just to remind them that although they have antibodies there, that they don't provide protection from reinfection. And so if they engage in any high-risk behaviors, they could be reinfected. And that could be, I have that same conversation with people that maybe got it from a blood transfusion in the late 80s up to my people that have a history of intranasal or IV drug use. So I want to make sure that they understand that.
And actually, just as a reminder, because I don't know if everyone that's on today was on the first time you said this, Dr. Collins, but you mentioned people reinfecting themselves with an old toothbrush or razor, something like that. And I just thought that was...
Yes, it's not in the guidelines, so I'm not actually putting it on our post-treatment worksheet, but there is evidence that Hep C can stick around for sometimes weeks to months on inanimate objects like razors and toothbrushes. And there's some, at least theoretical possibility that people could get reinfected. I tell people, and I think Jen does too, when they come back, what I usually try to do is when they come back for their first follow-up visit, I tell them to get rid of everything that they've used before.
Yeah.
So that's just what I do. But that's not in the guidelines. So I'm trying just to give you what's really in the guidelines because it's a theoretical concern. I don't think we've ever seen a case documented where that's happened. It's just theoretical. It's hard to know whether it happens because people sometimes, think, well, they got reinfected because they started using again. It's hard to know, did they get reinfected because they used some of their old stuff, or did they get reinfected because they started using? You'll get the same virus back either way. Well, actually, if you get reinfected, sometimes you won't, but still. So that's kind of a theoretical thing. We do talk to people about that, but if you don't do it, I don't think it's the end of the world. Okay. So at that point, I think you're actually really done. And you just got to remember to do the ultrasound and the alpha-fetoprotein level every 6 months from there on. Okay.
Great.
Any questions about this one?
Yeah. Questions, comments, thoughts?
Can you guys make it through the site okay? Does that work for you? I hope. Let's go back one more time.
Laura, have you been able to follow along on the website at all?
Yes. Yes, I have. Thank you.
It's harder if you can't necessarily see what's in front of you, but.
And I do want to point out just a couple of other things. I'm going to let Jen do her case if we have, I don't want to take all your time. But look at the medication quick comparison, which is all the additional information. I want you to still use the drug interaction checker, but it is a quick thing to just look for the very big stuff. Like it'll say on there that Epclusa, Harvoni, amiodarone is going to be in bold on this thing. There we go, it's coming. So it says important drug interactions. If you see there's Harvoni, Epclusa, amiodarone is in bold letters there. So this is a quick thing. It's not meant to be comprehensive, and if you scroll down just a minute, you're going to see that Mavyret, which is the last one down there, it says statins in bold. And that's why this is like this, because we want to give you the ones that are really, really, really like, they could kill people if you did it kind of thing. We had a case of, I'll say that because I want you to do your case. Okay, let's go back and let Jen do hers.
You just got
Okay, I'll go out and you do.
7755. Okay, so Jill, you with me?
I am.
Actually, I wanted to do this one just because this is going to be the sort of typical patient that you're going to see. I tend to see more of the younger crowd. So this is a patient who is 34 years old, female. Fidelis has an insurer. Past medical history, really not much. Depression, and this is what I tend to see, somebody who's got depression, anxiety disorder, PTSD, who has a history of IV drug use or intranasal drug use, tattoos that have been done outside of a licensed parlor. Year of diagnosis was 2015, so not been hepatitis C positive for very long. Most recent viral load, 457,000. Most recent HIV test is negative and not co-infected. And in fact, this person has a positive Hep C antibody, positive Hep B, surface antibody, so they're immune because they have a negative Hep B core total antibody. Their hepatitis A total antibody is negative, so I would certainly consider giving them hepatitis A immunization during treatment. So if we go to, we'll just quickly click on to the pre-treatment worksheet, and we'll kind of buzz through this. So this would be the, like I say, the typical kind of case that you'll see. So patient wasn't infected in the past 6 months. We had a positive antibody test in 2015, and they still have a measurable viral load now, so we know this is chronic. Hepatitis C genotype was actually genotype 3. Patient has not been previously treated, so this is a treatment naive patient. And this is somebody, you know, when I calculate their FIB4, and just in the interest of time, we won't go through the numbers, but you could click on the staging algorithm and you could do the calculated FIB4, which comes out to 1.09. So it's actually, just click on the staging algorithm for 1 sec, Jill. So the 1.09 falls onto the left-hand side of the screen under the green area, the FIB4 of less than or equal to 1.45. So I'm fairly confident that this person doesn't have underlying cirrhosis, and I would kind of stop there. I'm not going to do FibroSure or liver elastography, that type of thing. As part of this patient's history, I know that they've never really been a big drinker. Their sort of preference was to use pills and IV drugs. And so given that, and given this FIB4 score, I'm going to stop there and go ahead and make a treatment decision for this patient. So we can go back to the pre-treatment screening stuff. Right. So then we can look at the guidelines.
Let me just tell them really quickly, though, because when you do this part, you have to maximize this page, because if you don't do that, and if you hover over the treatment naive and try to go across, it won't let you go across. So you got to maximize this page when it does come up. Okay, sorry.
So this is a genotype 3 patient with no cirrhosis. So these are our 2 recommended, right? So we've got glecaprevir, pibrentasvir, so Mavorette, or sofosbuvir velpatasvir, which is Epclusa. That's the generic form of Epclusa. And actually, most, I think, of the drug formularies are asking for generic Epclusa. So either one are good choices. So the next thing would be, what are potential drug interactions when we look at this patient's medications? So Jill, if we go back to the main page, and then we go on drug interaction checker, hopefully, yay! So Jill, if you would throw in Mavorette and Epclusa for me. Nice. So this patient, and this is kind of typical for what I see when you have these patients with depression and PTSD and IV drug use. So they're on buprenorphine, right? There's a lot of people that are on Suboxone or Subutex. And so we'll put that in first. Excellent. Gabapentin is another one that they're commonly on. So we'll look at gabapentin. So GABA, there we are. Hydroxyzine, commonly seen in this crowd. There we are. Bill, you're doing awesome.
Yeah, she is.
You?
Trazodone.
Hopefully that comes up there. If it does. Yes, it does.
Citalopram. CITA. Excellent. And Seroquel, which is QUETIA.
Yeah,
Won't come up. You have to do QUE. There we are. Perfect. So if we look, we see with Seroquel and Mavorette, there's a potential interaction.
Can she now get their PDF and they see it?
I don't think so. You could try. Can you click on the PDF and see if it will all come up, Jill?
Yeah. Let me get that out of the
And
way.
see if they can see it as one big thing, which is nice.
Nice. Can everybody see? Perfect.
This
Okay.
is, yeah, this is a PDF. This is why this is so nice.
So Jill, if you can scroll down for me. Right. So we see with Mavorette and Seroquel, potentially clinically significant interaction, right? So it can increase the levels of Mavorette. So it's a weak inhibitor, CYP3A4. But that's okay, because I still have sofosbuvir velpatasvir that I can use. So if we scroll down, we see that there's a potential weak interaction between the generic Epclusa and buprenorphine, but it's a potential weak interaction.
Let's
So
go down more. I don't think they can.
If
Oh,
we
no,
could-
they can. I'm sorry.
right, so they can see, and I'm not particularly worried about this. They're saying it may, concentrations of buprenorphine may increase, but this is a potential weak interaction, so I'm not particularly worried about it, okay? And then if we scroll down further, we see that with the rest of them, we're okay. So probably in this instance, given what I've seen here, and I know that the insurance is actually going to prefer the sofosbuvir velpatasvir, that's what I'm going to select for this patient. Okay? So the sofosbuvir velpatasvir, and we can go to the main page here, and we can click on the Epclusa worksheet, because it's the same thing. So now we're looking at somebody who's going to get 12 weeks because there's no 8-week option with this. Eligibility, so any genotype. This is a genotype 3 patient. We know they don't have cirrhosis. And so, I mean, regardless, this is a 12-week long drug. So this is our time 0. We're starting most recent viral load, which I talked about was 457,000. So down at the bottom, that's what we would look at. We don't need to measure LFTs with this drug. So then the patient I would order the medication. Patient's going to start taking their medication. They're going to get a viral load done after about 3 weeks, as required by the insurance company. Assuming that the viral load has dropped, and typically what you'll see at this point is that they're probably near to or undetectable. So then after they've completed the 12 weeks, we have them do the blood work after they've taken all their medication. And I make sure to remind them of that. Don't do it early. I tell them just make sure after you've taken all 12 weeks of medication, then go get your viral load done. And then we see them back in follow-up at 14 weeks to discuss their end of treatment response. And we're, a fairly safe bet that they're going to have an undetectable viral load at that point. And then at that, we'll schedule them for a follow-up, another 13 weeks out. So at 25 weeks, this is 12 weeks post-therapy, we're going to repeat viral load. And then we're going to look at, have them come back and talk about their SVR or their sustained virologic response. And assuming that they remained undetectable, at that point, you're done. Okay? So that is your sort of standard patient that you're going to see. And that's how we kind of work through the decision-making process. And I'll close that out and say, does anybody have any questions about that one? Does that kind of make sense? My reasoning made sense to you, and you get why I didn't go any further in terms of fibrosis testing or elastography, that type of thing? Okay, good. And I just wanted to showcase a patient these are the typical drug combinations that you're going to see in this sort of history of IV drug use patients. They're going to be on buprenorphine or some version. They're going to be on gabapentin, hydroxyzine. You'll see a lot of patients with mental illness that are on Seroquel. So there you have it. Your standard Hep C patients.
Exactly.
Yeah.
One thing I wondered if you guys may be wondering about, because I am too, and I think if you use Epclusa this day and age, which is now generic, it's pangenotypic. Use it whether you have cirrhosis or not for 12 weeks. You could argue that a lot of what we were actually having to jump through, the hoops we have to jump through right now, are unnecessary.
Right.
And it may be that the guidelines will change soon to let us not have to jump through so many hoops of getting genotypes when we don't really need to know the genotype anymore.
Yeah.
If you're using Mavorette and Epclusa, does it matter what genotype they are? Probably not. But this is what the guidelines still say we need to do right now. But in the future, when we get more and more generic pangenotypic agents, we may stop having to do some of the testing we're doing right now, and then it'll just be a sense of I think the thing you'll be left with is making sure they don't have cirrhosis, so that you can figure out whether they have compensated or decompensated cirrhosis. But the length of treatment is going to be the same.
Yeah.
So
For
I
now,
I have a
Go
quick
ahead.
question. I know it's almost one. The part where the patient is acutely infected within 6 months.
yes.
right?
So I wasn't there for the earlier lectures, but why is that? Why are we referring to a specialist?
Well, if you're going to treat, you don't need to. But what we will often do is we will wait and see if they clear it, unless we really think that for some reason we can get it paid for, or that we're really worried about them spreading it and try to treat them then. But basically what we'll do, since these drugs cost so much, is we'll watch them for 6 months and see if they clear it on their own, because 20% will. But you have to be
Right.
careful, because I've had this happen, which is in that first 6 months, if they are acutely infected, the viral load can become transiently undetectable and then pop back up. And so you want to make sure that they really are undetectable beyond 6 months. And so that's why we had some caution about having people treat acute hep C or manage acute hep C, because a lot of people get watched because the drugs are so expensive. If these drugs weren't so expensive, we would just, and I think it would make sense to treat everybody, because again, treatment is prevention. But right now, a lot of insurances want to make sure that they're done, that if they are acute, they want you to wait 6 months anyway, because they don't want to pay, obviously. Does that make sense?
Yeah, thank you.
Yeah, sure.
Great question.
Definitely.
Yeah, that actually happens quite a bit. We get patients sent to us who have just gotten, like they just went into, say, rehab, and they had a positive hepatitis C antibody test done. And that's the first one they've ever had. And so you meet them for the first time. And by history, they tell you, oh, I started using IV drugs 8 years ago. So you suspect that they're probably going to be chronically infected. But because it's the first time they were ever tested for antibody, then I say, let's wait 6 months, have you come back, and then we can prove it. So long as they're not showing like signs of imminent liver failure, that type of thing. But these are people that are usually pretty stable, and they may have like slightly elevated LFTs, but otherwise they're completely healthy. And we'll say, let's just, the insurance company is going to insist, so let's just wait the 6 months. We'll do a viral load at that point and see if it's still there. I feel like it's going to be, but you will see people who they have just gotten diagnosed. So then I may say, let's repeat 7-8 months out, just to make sure that we don't miss something.
And one other point that is important on the acute infections, there is an exception to waiting, and that is if you have cirrhosis already.
Right.
Then you don't want to wait 6 months. You want to treat right away, and the insurances will let you in that situation. You may have to write a letter to do it, but you can get it done.
Yeah.
And that's another reason we said, we want to take that headache off your back. We'll deal with those people. But you can do it. I mean, you guys have the capability of doing it. It's just that we tried to make it to where you wouldn't have to deal with too many of those kind of issues. That's all.
Got it. Thank you.
Yeah.
Sure.
Okay.
All right.
It's 1 o'clock. Thank you so much for joining
Thanks.
us.
We'll let everyone go. Have a good weekend, and we'll see you back on March 21st, please.
Everybody
Thank
can
you.
get to the site, right? Everybody has a way to get to the site? Yes.
Yes.
Okay.
Great. Thank you.
Thanks for your help, Jill.
And Raju.
Yes, and Raju.
Yes, exactly.
Yes.
You're welcome. Thank you.